So we're moving on into chapter 12. This is going to be our anti-inflammatories, our anti-arthritis, and our anti-gout drugs. So just be mindful as you move through this presentation that this tends to be one of the harder chapters for most of the students. So if I say to you, you absolutely need to understand this, or I have other trigger words as you will see this again, you need to know this, or you need to understand this, you might want to take some notes. Most of you are doing extremely well in this course, and you should be proud. So I just wanted to throw that out there as we begin this chapter with our anti-inflammatories. So moving through this chapter, we're going to talk about some chronic inflammatory conditions of the musculoskeletal system, and there are four primary categories. So again, that's going to be your NSAIDs, your corticosteroids, your disease-modifying anti-rheumatic drugs, or DMARDs is what you will typically refer to, and our anti-gout drugs. So those are the four primary categories that we're going to talk about. It doesn't seem like a whole lot, but when you start diving into the information, there's a ton of information about each and every one of those categories. Okay, so again, if you have any questions, I know this is a completely different learning system, but you guys have adapted well, and you seem to be doing really well considering all the circumstances. So just continue on. If you have questions, please do not hesitate to reach out to me. So as we talk about inflammation and injury, we're going to talk the inflammatory process, the importance of it, whether it's fighting tissue damage or infection, and some chronic inflammation. So when tissue is damaged either by some type of infection or injury, then our body releases chemicals or the mediators that your book talks about called cytokines. This is an important part of the inflammatory process because they do several different things. So at the beginning of an injury, what happens is the histamines send a messenger to our body that begins to dilate our blood vessels. Those little arterioles become larger, and they begin to become, I guess, um, leaky. They become leaky. That's a good word. So as they dilate and they bring more blood into the affected area, that's where we get the warmth and the redness from. So other cytokines that are released attract white blood cells to the area. And so they begin immediately fighting any type of infection that might be present. And so then at the same time, the process of repairing that tissue begins. Now, as those that leakage continues from those little arterioles, that's where you start to see the swelling, and that's where the pain comes from. Okay, it's just putting pressure on that tissue and any of the nerves that are there. Okay, so kinins are what trigger the pain receptors in those nerve endings. Okay, so that's where the pain comes from. Now, the warmth itself actually comes from cytokines also, because some of them are actually considered pyrogens. So they begin to raise the temperature at that site. Okay, so as we know, some bacteria can't live in warm environments, and if it's an infection process, or you may actually have an increased overall body temperature, okay, rather than just that warmth at the site. So really the goal of the inflammatory process is to destroy infections and repair tissue damage. So the increase in temperature, again, makes it difficult for that bacteria to grow. So with chronic inflammation, this meaning it's just something that's gone untreated. Okay, you've had some type of inflammation and you've just never taken anything for it. So in a short-term sense, the inflammatory process is great. Okay, it creates pain and swelling, and it triggers our body to start the process of healing. So in chronic inflammation, it's a little different because that inflammation goes untreated. So it never goes away. That tissue is never repaired. So it creates a chronic problem. Okay, you end up with damage to the tissue over a long period of time, and sometimes even necrosis and death of that tissue. Okay, so it can be very debilitating. A couple of chronic issues that might come to mind, of course, is going to be your arthritis. Okay, shoulders, knees, ankles, hips, most of the time in your larger joints. So just be mindful of what the inflammatory process is and how important it is to our body and what the goal is for the inflammatory process in the short term. And then, of course, left untreated creates those chronic issues. So once we have an injury, we have mediators that start performing. So they can continue that inflammatory process. So we have prostaglandins. Okay, remember we talked earlier about the they're chemicals that actually start that inflammatory process. Okay, so kinins is the mediator that is released to trigger those pain receptors in the nerve endings, therefore creating pain or the feeling of pain at the site. Now, arachidonic acid, we'll talk a little bit more about it in the next slide, but it actually increases inflammatory response. It's converted from phospholipids. Yes. So it's produced from converted fat, which is then turned into different mediators by what is called cyclooxygenase, or COX-1 and COX-2. And we'll talk about those in the next slide. So histamines, of course, just simply act on the blood vessels at the site. Once we receive an injury, that histamine starts to dilate those blood vessels, allowing more blood flow to the site. Now, tumor necrosis factor, or TNF as you typically see it, is a cell signaling protein. Okay, so it's a cytokine. It's produced by macrophages. And remember, macrophages just basically go in there like the Pac-Man of, I don't know how you would describe that, but I would guess maybe the Pac-Man of yuck, bacteria. Okay, it goes in and eats all of that stuff up. Okay, so the tumor necrosis factor is also able to induce fever, so it is an endogenous pyrogen. So tumor necrosis basically is multifunctional, I guess is the best way to talk about it. It can actually do a couple of things. It can either promote cell survival or it can promote cell death, which is typically called apoptosis. Okay, so it's sometimes also associated with carcinogenesis, which is the beginning of a carcinogen, like in a tumor. Okay, so that's why I call it a multifunctional cell. So it can either suppress a tumor cell from growing or it can promote cell growth. Okay, so it can go either way. So as we talk about the TNF in the next slide, you'll understand what we're talking about. So these are just a couple of things that are parts of the inflammatory process. So just be familiar with those, and we'll talk about them in the next couple of slides. This is just an insert so that you guys can visualize what I was talking about in that arachidonic acid coming from phospholipids, okay, and how it breaks down into the cyclooxygenase, okay, the 1 and 2. So I just kind of put this in here for a visual for you. So just wanted to make sure that you understood what I was talking about. Sometimes with a visual, it is a little bit easier to understand. So sometimes inflammation is not good for the body, okay? If you have diseases like rheumatoid arthritis or psoriatic arthritis, so your immune system is confused about what to attack. So it goes after our healthy body parts, like your joints.
unintentionally. Okay, it's just confused. So some of the more common autoimmune disorders are your RA, lupus, psoriasis, multiple sclerosis, Graves' disease, and then some of you may have heard about Hashimoto's thyroiditis. That's where it starts to turn on our own thyroid and attacks our thyroid. So an autoimmune disorder again is just attacking and damaging our own tissues, our own healthy tissues, okay? So in these patients, what you're going to see is an increase in that tumor necrosis factor, which is part of the inflammatory process. So it's part of our natural body defense, but then it can also be destructive. Remember, I think I've talked about how TNF can either prevent or influence the growth of certain cells. So these patients have that higher TNF. So it fails to recognize um, the normal body cells. Okay, so then it just attacks the tissue. So because of that continuous release of that TNF mediator, this is where we get into our chronic issues, okay? Now, psoriasis, this is where one of the things you will notice in psoriasis or someone who has psoriasis is on the skin, you'll see those red raised areas. So this leads you to think about that inflammatory process and the redness that appears, okay? So just a couple of things about the tumor necrosis factor. I wanted you to understand some of those autoimmune disorders and why that happens. Okay, so if you have any questions about that tumor necrosis factor and how it leads to these autoimmune diseases, then please just let me know. I will explain it further in detail, just like I have always encouraged you to do so. Don't ever hesitate to send me questions. So just a couple of tidbits about those autoimmune disorders.
Okay, so let's talk about NSAIDs a little bit more. We've talked about them some in the previous chapter, but we're going to dive into the actual categories in this chapter here. So again, non-steroidal anti-inflammatory drugs. So there's two categories. You have non-selective and selective. So knowing the importance of what COX-1 and COX-2 actually do is important when it comes to treating whatever it is you're trying to treat by knowing what non-selective and selective NSAIDs affect. So you'll see on this slide, I have them broken down for you. There's two categories, the selective and non-selective. So you'll see the non-selective inhibits the action of both COX-1 and COX-2. Now remember, COX-1 is our good COX and COX-2 is bad. Okay, so the selective only inhibits COX-2. So looking at the non-selective, if you remember, of course, we said COX-1 is the good COX, and it actually produces the thick mucosal lining in our GI tract to protect that from the stomach acid. So if you're taking an NSAID that's inhibiting COX-1 enzymes, then we're decreasing the ability to produce that mucus and that mucosal lining. Therefore, our GI tract is more susceptible to the acid and more vulnerable to ulcerations and things like that because we don't have that protective lining. Now it happens a lot with chronic users, those who have some type of chronic inflammation because they're taking it and they don't feel like they're getting as much of a relief as they should, so they begin to take it more often and not following those guidelines every 6 hours or whatever. So then those are the patients you see with GI complaints and ultimately ulcers. Now, non-selective NSAIDs also prevent blood clotting, that platelet aggregation, and the reason for that is you'll see I have aspirin listed in the non-selective category, and that's why. So again, aspirin prevents that and prolongs bleeding, and if you're taking it regularly for some type of chronic issue, then you are at higher risk for a prolonged bleeding time. Okay, so you have aspirin, ibuprofen, and naproxen in the non-selective categories. Okay, so when we take a non-selective, it depletes our GI lining. It still reduces that pain and inflammation and also fever. Okay. Now, some of the non-selective medications, of course, again, are your aspirin, ibuprofen, and naproxen, and most of those you can get over the counter. You don't have to have a prescription for. Now, some naproxens have a higher dose, a much higher dose, or like 750 or greater. Those do have to have a prescription. So one of the things to be mindful of when you're assessing your patient and they're taking some type of NSAID is looking to see if they are in fact taking some other type of blood thinning agent, warfarin, Coumadin, something like that. So you can see by this slide that when we take the non-selective, we're actually susceptible to more side effects than with just the selective. So it's selective NSAIDs are only inhibiting those COX-2 enzymes. So our GI is still protected. We are not going to have that blood clotting issue because we're not taking aspirin, and it still reduces our pain and inflammation. Okay, so the selective ones are going to be your celecoxib and your meloxicam. Now those typically always have a prescription for those. So you still get the same anti-inflammatory response and the pain out of both of them, but with the non-selective, again, you have those additional side effects of that reduced GI lining and the increased risk of bleeding. So when we're comparing the two, the non-selective and the selective, you would notice that it would be most likely that your chronic patients would be taking the selective NSAIDs, your meloxicams and your celecoxib, just because they're taking it more often, and we don't want to increase their risk of bleeding and risk of ulcers. So again, your selective NSAIDs are going to be for your chronic patients. Selective also would most likely be taken for menstrual cramps. That way you're not, again, inducing any of those other side effects with the non-selectives.
So I put this slide in here so that you can see some of the side effects and have a visual for them. So we talked about the arachidonic acid and how it it breaks into the COX-1 and COX-2 through the cyclooxygenase. So I want you to see how each of them perform. So the COX-1, you can see we've talked about this. It increases that mucus that protects that stomach lining. Again, it increases that bicarb, which is a buffer for the body. And again, just that mucosal blood flow. So that's what your COX-1 does. So now COX-1 and COX-2 on the kidneys, you can see it works with the prostaglandins, okay, and then vasodilation. So this is where your kidneys come in with that GFR, your glomerular filtration rate and all that. So it helps to increase that sodium and water excretion so that we don't have that excess edema and things of that nature, okay? So then you can see how it affects the cardiovascular system. This is when we talked about the platelet aggregation and the vasodilation, okay? So when you look below the three boxes, you look for what happens when we inhibit those things. So with COX-1, you're going to get those peptic ulcers and GI bleeding, okay, that prolonged bleeding. And then again with 1 and 2, what you see is that water retention, some edema, okay, hypertension, and then that kidney injury because the flow is not working as though it should in our kidneys, okay? And then in the cardiovascular system, this is where we were talking about the stroke and the myocardial infarction because it's constricting everything that's in there. So we don't, we certainly don't want to cause any harm to our patient. So always looking at that health history at their risk. Are they already at risk for stroke or some type of cardiovascular event? Okay, so just wanted to give you a visual to kind of let you see that. Sometimes it's easier if you have a visual rather than just listening to someone talk for hours on end about certain things. So just take a look at those. This is a really good example as to what they do, and then when we inhibit them, what we're causing, okay? So just be mindful of those, and if you have any questions, again, just send an email to me. So uses of NSAIDs, of course, they should always be our first line of therapy for pain and fever associated with inflammation. Again, avoiding aspirin in children. Now, aspirin is widely used in patients after an MI or heart attack, however you want to describe it. It's all the same thing. And the reason for that is typically we want them to have thinner blood because they've either had some type of clot form that's caused an MI, something of that nature. So we want to inhibit that platelet aggregation so that they have less clotting going on. Okay, so aspirin is used many times after cardiac events to reduce that clotting process to avoid future heart attacks or myocardial infarctions. Okay, so just know typically what they're used for, first line defense, and that they are typically used after a cardiac event in order to thin out that blood to prevent further complications or additional heart attacks. Let's look at some of the side effects and the adverse effects of NSAIDs. So some of the common ones are heartburn, nausea, and vomiting. And of course, this comes from typically taking them on an empty stomach. So again, that's where we want to educate our patient about taking it with a full glass of water and with a small amount of food or even milk if they have that heartburn after taking NSAIDs. So dizziness and the headache is linked to the cardiovascular aspect of the COX-1 and COX-2 inhibitors. And so the pain of that headache is suspected to come from that constriction dilation of blood vessels. So if you look at the previous slide, you'll see that constriction and dilation in the cardiovascular part. And then, of course, increased risk of bleeding that comes with your non-selective patient and the patient who's taking the non-selective aspirin. So again, just reminding them to take it with a full glass of water, small amounts of food or milk. Remind them not to take their NSAID and go lay down at night. Okay, we don't want them doing that. That just increases their risks. So allergies and anaphylaxis, we always want to make sure that anytime we're giving medication for the first time ever, that we're assessing for those allergies, no matter where we are or what we're giving. And then GI bleeding, we talked a little bit about that. Some of the things to look for. Remember those initial signs is going to be maybe petechiae and bleeding gums when they're brushing their teeth and things like that. So clot, stroke, and infarction, of course, are going to be your adverse effects, and that comes again from that cardiovascular aspect of the COX-1 and COX-2. So if you look back at that slide, I think number 9, it talks about the vasodilation and the vasoconstriction. So that's where that comes into play. If you have a patient who has a history of some type of cardiovascular disease or at a much higher risk for stroke or heart attack, then you want to be mindful of using them cautiously in those patients. And so that's where it's important to, again, go back and look at that health history. Now, of course, we've talked about Reye syndrome on several occasions, and we absolutely do not want to give aspirin to children. Okay, remember we talked about Reye syndrome and that it affects the brain and liver, and it can be very detrimental, even causing death. Okay, so no aspirin to children. Now, salicism is, of course, aspirin toxicity, overdose, basically. They've taken way too much. So some of the signs that you'll see for salicism is going to be tinnitus, which is that ringing in the ears. That's what you typically hear your patients talk about, but it's just a noise, basically. Some others may experience a different type of clicking or something else, but typically it's ringing of the ears. They're going to be sweaty and they're going to flush, and that just goes back to that extreme dilation, okay, and then that fever control from that cyclooxygenesis. I'll get it out in a second. So that just comes into play because it again controls that fever, okay, so the flushing probably comes from the vasodilation. Now, if you are in a facility and this is what you are assessing in your patient, and you of course don't want to give them any other aspirin. You want to stop giving it and notify your physician or their physician immediately. Okay, so it's very important. So just be mindful of the side effects and the adverse effects, what to assess for, know why you're assessing for that. Again, going back to those clots and strokes and infarction, just making sure that you understand the importance of the increased risk that they're taking when they take those medications if they're already at risk. So just be sure you understand the adverse effects, the common side effects, and what to do about those. Okay, remember that full glass of water, small amounts of food, milk, and again, assessing for any other medication that might also prolong bleeding. Okay. Okay, so let's talk about NSAIDs with drug interactions and some other interactions. So alcohol, of course, we all know that it thins our blood, so therefore it's increasing our risk of bleeding. So caution your patients about the use of alcohol. Anticoagulants, we talked about warfarin. Remember, of course, they're taking those to thin their blood because maybe they've had some type of cardiovascular event and they need thin blood. So if we also take NSAIDs on top of that, then we're increasing that bleeding time again. So vaccines, we don't ever want to give NSAIDs with vaccines, particularly live vaccines. Again, you have to think about what it's doing to our system. Remember, we're suppressing that immune response. So when we take a vaccine, we want our body to build up that antibodies against it. And so if we give a live vaccine particularly, then can it actually fight that off? And so if we're injecting something that's live, then it's suppressing our immune system to fight that off, we run into problems there. So remember, we don't ever give NSAIDs for vaccine-related pain or discomforts. Pregnancy is a big thing with NSAIDs. So there's a couple of different things. There's ibuprofen and then there's indomethacin. They're both in the same category of NSAIDs. So ibuprofen, especially in the first trimester or so, has been shown to sometimes cause miscarriage. Okay, now if you use NSAIDs after about 30 weeks of pregnancy, it closes the PDA in a fetus or can constrict that. Okay, so the PDA, if you guys know anything about pregnancy or labor and delivery, that is the patent ductus arteriosus of the fetus, which that is their circulatory system. Now it flows differently than us outside the body. So once that fetus is delivered, oftentimes that PDA will just automatically close. Okay, their circulatory system switches. So if it doesn't close on its own after delivery, then sometimes we give indomethacin to close that PDA, but we don't want to do that prematurely. So you have to be very cautious in avoiding NSAIDs during pregnancy. Now, indomethacin also is given sometimes to prevent premature labor, because going back to that cyclooxygenase, it is actually one of the enzymes that has an influence on acute contractions. Okay, so cyclooxygenase has many things that it performs and affects. Okay, so that's why we want to be very cautious in using NSAIDs in or during pregnancy. Okay, so always caution your patients about those interactions if they're pregnant or planning to become pregnant. Okay, so we talked about sulfonylureas. That's hard for me to say sometimes. Those are your anti-diabetic drugs. Okay, your glipizide, your metformin, and we talked about what those interactions were. So I'm not going to go back over those. You can just go back to that same slide and look at those. So sulfonamides, these are your, this is the basis of your sulfa drugs, okay, your basic structure of sulfa drugs. So remember those COX-2 inhibitors, the meloxicam and the Celebrex, they too have that same basis of a sulfa drug. So be mindful of those interactions, okay. Antihypertensive drugs, it can affect those, okay. So your ACE inhibitors, those are your angiotensin converting enzyme inhibitors, okay. So these are your prils. This is your lisinopril, your captopril, those type of things. So ACE inhibitors work by relaxing those blood vessels to lower that blood pressure. Okay, so if we are inhibiting an inhibitor, then we're not lowering that blood pressure. Okay, so it also affects beta blockers. Now your beta blockers, if you've been studying, those are your OLOLs, like your metoprolol, your labetalol, and your atenolols. Okay, so you may see those on someone's allergy list or things like that. So you'll know what those are. So the beta blockers, those work by just slowing the heart rate, by blocking that effect of epinephrine. Okay, so by blocking the effect of epinephrine, our heart rate slows down. Okay, we don't have that adrenaline pumping around in there. So those are some of the interactions. Just look over those, go back and listen to them again, and if you have any questions further about the interactions, then please email me. Like I always say, I'm more than willing to dive back into that or explain something a little bit further if I didn't quite explain it to you in this lecture in a way that you can understand. If I need to elaborate further, please let me know. Okay, that's why I'm here. So again, those are your drugs and your interactions, and know why they're interacting. Your vaccines and with pregnancy and those types of things. Okay, so let's move on. So with our nursing assessment, there's a couple things that we have to be mindful of. Remember, we're talking about that cyclooxygenase, and then it divides into the two, COX-1 and COX-2.
So cyclooxygenase, of course, is present in different cells, and it helps maintain, first of all, renal flow. Again, it mediates fever. Okay, this also transmits perceptions of pain. And then another performing, or another thing that the cyclooxygenase performs is the control of bicarb. Okay, and bicarb is our buffering system in the body. So that's where our GI tract and that protective lining comes into play. Okay, so when we're doing our nursing assessment, it's good to know a couple of those things. Excuse me, sorry. Um, when we start our assessment. So number one, we want to do our drug reconciliation. Those are always important. We want to make sure that they're not taking any other medications that contain aspirin, like your warfarin, your Coumadin, anything like that, that might be a blood thinning agent. Or you also want to assess for other medications that might have a side effect of decreased platelets. Okay, so you want to be mindful of those. Now, when we are also doing our assessment, we want to assess for appropriateness of administration and the correct route. So if I'm giving a patient a pill, can they swallow it? Okay, those types of things. So just being mindful of if that patient can safely either swallow, or if it's some type of injection, something of that nature. Always assess for their ability to safely take that medication in the route prescribed. Allergies, we always assess for allergies. We want to make sure we always assess that before we ever give a medication for the very first time, no matter what the medication is. Okay, so we know that one of the COX inhibitors is aspirin, and so that's the non-selective. So it can increase bleeding time. We've heard that millions of times. So a couple of signs that we can look for with bleeding is going to be petechiae, those little purplish spots that you see. Now, with non-selectives, remember when we take that GI protective lining away, we're at risk for ulcers. Now, ulcers can be silent bleeders, okay? You may not notice that, except in maybe stools or just those GI irritations, okay? So you have to be mindful of also educating your patient to be sure that they're reporting any type of like gray, black, tarry stools, okay? Because it could be a sign of, again, that silent bleeding with a GI ulcer. Now, a couple other places where you would first notice bleeding is in the mucous membranes, gums. No one really ever thinks about that, but um, gums is one of the first places you're going to see that, okay? In that mouth, in the gum area, brushing your teeth. They may not ever think of that, but that's one of the first things. So also going along with bleeding is going to be monitoring some labs, those platelet counts. Remember we talked about when we're doing our drug reconciliation, are they taking another medication that affects platelets? So if so, we need to be doing those platelet counts. And then if they were to have a hematocrit and hemoglobin, so where's that blood going? Why are those labs low? Okay, so a couple of things that we can assess when we're, especially our chronic patients who are taking NSAIDs. So a couple other things to monitor for or assess for is kidney function, liver function, and then of course our GI. Now, as I said, of course, with the kidney, it helps maintain the flow, the renal flow. That's what your cyclooxygenase helps with, partially. It's one of the functions. So we wanted to monitor that kidney function. So always talk to your patients about taking it with a full glass of water. Okay, you will see that again on a test. I promise you. If you don't, you'll see it on your NCLEX or even ATI. So take with a full glass of water just to make sure that they're hydrated. And remember, of course, water is our universal solvent. So it's immediately going to start that breakdown process of that medication. Okay, that dissolution or dissolving of that medication. We also want to prevent kidney damage. So we want them to stay hydrated. So just, educating them about drinking, X number of ounces of water a day. Liver, we want to make sure that they don't already have some type of liver disease because we don't want to, continue causing damage to the liver. And then we've talked about our GI tract and how It does play an important part in that mucousy lining that protects our GI tract from that pH, that acid that's produced there. So those are just a couple of really important things when we're doing our nursing assessment with someone who is either taking a new prescription for an NSAID or already takes NSAIDs. Okay, so just a couple of those things to be mindful for. Especially your bleeding, know what to look for and some of the places where you might see them initially. Planning and evaluation. So when we talk about NSAIDs, and we want to always make sure that we're looking to see that we are in fact giving the correct dosages in the correct route. So there's several different routes of administration and dosages for NSAIDs. Of course, aspirin, if you look on page 228 in table 12.1, you'll see the variances. So aspirin is 325 to 650 milligrams every 4 to 6 hours. And then, of course, they have an extra strength, which is 1,000 milligrams. So if you're taking 1,000 milligrams, you're not going to want to take that every 4 hours. So that one is every 6. And then if you scroll on down to look at some of the others, now ketorolac, which is also Toradol, is also an NSAID that's used in ophthalmology. So it may have a different dosing rather than oral. So you'll see just the various different dosages in the routes. So be mindful of checking those labels and educating your patient to check those labels and make sure they're using them correctly. So monitoring for effectiveness. So if you give an NSAID, did you see that fever decrease? Again, this goes back to assessing your patient just as if you were giving a, morphine or something. You have to go back and check for effectiveness, okay? Because you don't want to keep giving it if it's not working. So did their fever go down? Okay, was there a decrease in pain? Now, of course, with NSAIDs, if you're using them for like chronic inflammation and you're just starting that prescription, it may take a week or so to really see that effect. So it may not be immediate if there's some type of arthritis that you're treating. Okay, so then observing for the signs of toxicity, we talked about those, but let's just review some of them. Of course, vomiting, ringing in the ears, that tinnitus. You may have some confusion. Hyperthermia, remember it regulates the fever, okay? It's a pyrogen, okay? It can actually lead to some organ failure, okay? Remember we talked about, especially in children, how it affects the liver and brain. So it can also affect the liver in adults just as well if you're overdosing yourself. So just know some of those signs of toxicity and what you would assess for in a patient if you suspected that, okay? I think that's pretty much covered most of it for evaluating. And just remember, again, of course, if their fever didn't go down and there wasn't a decrease in pain, we don't want to give them, continue to give that. They may need something different, okay? Or there may be something else going on. So we really want to assess that and report that. Okay, so let's talk about education with our patients and NSAIDs. We all know that education is a huge part in compliance. So we always want to make sure that our patients are mindfully aware of side effects and anything that might be harmful to them. So we want to educate them on those side effects and that type of thing so that we can prevent those. So let's talk about first taking that medication with a full glass of water. We want our patients to be mindful of their kidney function. So kidney function depends upon the prostaglandins, remember, to maintain perfusion in that homeostatic environment. So in order to do that, we want to maintain that salt and water balance. So if you recall, I said NSAIDs decrease the production of mediators. And those mediators include that cyclooxygenase, which is important in maintaining renal flow. Remember, I talked about a couple of things that it does, maintaining that renal flow. It mediates fever.
and it increases the production of our buffer system, that bicarbonate, So just know that it plays an important part in our renal function. So with that being said, we want to make sure that if our patients are taking NSAIDs on a regular basis, that they weigh themselves, especially our cardiac patients or our heart failure patients. We want them to weigh themselves twice weekly, because a patient with heart failure can experience water retention, which worsens heart failure because we're overloading the body with excess fluid, which makes our heart work harder. And so as we make that heart work harder, our blood pressure increases, and we're causing greater damage to our heart. So you also think about excretion with NSAIDs. If our kidneys are impaired, are we excreting them appropriately? Okay. Are they remaining in the system longer and causing a greater risk for toxicity? Okay, so those are some of the things that you need to think about when we not only say take it with a full glass of water. We'll tell them why we want them to take it with a full glass of water. Okay, talk about those side effects or those adverse effects. Typically, we recommend that they take in 2 to 3 liters of water per day. So by doing so, we're addressing their hydration status. They're not going to be dehydrated and increase that risk of toxicity, and it protects our kidney function. Okay, it's going to maintain that perfusion, that blood flow. Okay, so hydration status is extremely important. So know how much to recommend to them, and know and understand why we're asking them to take it with a full glass of water. Okay, so some signs and symptoms of toxicity. We've talked about this several times. Again, going back to that vomiting, your tinnitus or ringing in the ears, maybe a state of confusion, and some hyperthermia. Remember, I just said that the cyclooxygenase plays a part in mediating fever. Okay, so we can also see some organ failure. If we are severely toxic, you may see some liver and kidney failure. Okay, so be mindful of that. Now, another very important thing when it comes to education is your diabetic patients. Okay, if you have a diabetic patient who's taking an oral anti-diabetic medication, metformin is one that comes to mind, they need to be checking that blood sugar often, because NSAIDs can interfere with how that drug is metabolized and used, okay, and it causes some hypoglycemia. So if you think also about NSAIDs, and if they're a chronic user or have a disease in which they use them every day, maybe they have some impairment in the liver and kidneys. Okay, remember, and it also goes through that first pass effect if it's an oral medication. So we're depleting the amount that's available to begin with. Okay, so just kind of understand why we want them to check those blood sugars. Okay, because it can impair the availability of that metformin. Okay, metformin is one that is not as affected when it comes to diabetic patients versus some of the others that are out there. So just know about your diabetic patients, encourage them to check their blood sugar often, and then educate them as to why we want them to check those blood sugars. Now, dosing schedules, we all know that not all of them are given on the same time frame. You have every 4 to 6 hours, depending on the dosages. Okay, you have some that are 12 hours. Okay, if you have one that's like 700 to 1,000 milligrams, you're only going to take that once a day. Okay, so just be mindful of educating them to, again, read those labels, check the milligrams, make sure they're adhering to the time frames or the dosaging allotments on those. Now, I think that pretty much covers most of this slide. So if you guys have any other questions about those, please let me know, and we'll talk about it a little bit further. So there's a few other things that we're going to talk about in the next slide as far as education, so we'll continue there. Now, continuing on with our education, there's a lot of education that comes along with the use of NSAIDs. So other over-the-counter medications. Are they taking other medications that we need to be mindful of? Again, that goes back to your medication reconciliation. So blood thinning agents, warfarin. Okay, it does affect warfarin because of the risk of bleeding. And it is to be taken serious, because if you're taking aspirin and warfarin, can you imagine their propensity to hemorrhage if they were to have some injury? Okay, so just looking for those blood thinning agents along with taking NSAIDs, okay, to prolong that bleeding time. Scheduled surgery, again, goes along with bleeding times. We want to make sure that if you have any type of scheduled surgery, whether it be an oral surgery, anything that you're going to have on your body that would bleed, of course, we always want to stop those, especially aspirin. Aspirin in particular is required 7 days. That just minimizes your risk for bleeding. Okay, now some of the other NSAIDs that they take may require 2 to 4 days. It just kind of depends on your facility or whoever's doing the procedure. But most of your aspirins are going to be minimum 7 days. Okay, some may require 10 days for aspirin, but your minimum for our testing purposes is 7 days. Okay. Now, we also want our patients to report fever. If they've been experiencing the fever and they've had it for 24 to 48 hours, and they have not seen any response in that fever, it hasn't gone down at all whatsoever, we want them to report that. Because remember, we're taking NSAIDs to prevent the inflammatory process. So if your patient continues to have a fever, there's probably something else going on, maybe some other type of infection, and our NSAIDs are masking that by inhibiting the inflammatory response. So it's decreasing our immune response and the protection. So if there's like some type of bacterial infection and we're taking NSAIDs, we're preventing that inflammatory process. And so by doing so, we're not sending out those phagocytes or, those little Pac-Man that come in to eat away at the bacteria. And we're also suppressing that ability to repair that tissue, okay? Notify the brain that there's something else going on, okay? So we're inhibiting that inflammatory response that would normally bring all of those things to the injury or that bacteria to begin the healing process. So it's important that they report that fever if it's been there for greater than 24 to 48 hours, okay? Now, allergies, of course, you can always have anaphylaxis we talked about, but particularly in this medication group that we're talking about, the COX-2 inhibitors, they are very similar to sulfa drugs. They're chemically structured about the same. So if you see on a patient's drug reconciliation that they are in fact allergic to sulfa drugs, it may not particularly say aspirin or, meloxicam or Celebrex. Those are the two in the COX-2 inhibitors. But just be mindful of, most of the time you're just going to see sulfa drugs. They may name those specifically, that Celebrex or the meloxicam, but it may just say sulfa drugs. So if they're allergic to sulfa, most of the time you don't want to give them those COX-2 inhibitors because they run the same risk of those allergic reactions. Okay. And again, avoiding these drugs to anyone who has a propensity for any type of cardiovascular disease. And we especially want to be mindful of smokers. Of course, they already have that vasoconstriction, so that would increase their risk. So those are lots of things to educate your patient about. Go back and read all of those on page 228. Look at those, be familiar with them, because I will tell you there are so many things on this test that refer to the nursing implications and the education for our patients when it comes to the medications that are in this particular chapter. So just be familiar with those. If you have questions about any of them, again, I'm always open to discuss those through email. So corticosteroids we talked about in the previous chapter, or they're otherwise known as glucocorticoids. It slows or stops all pathways leading to inflammation. Okay, and remember, it's a systemic result. It doesn't just affect one area. It's a systemic medication. So again, it is similar to our natural cortisol secreted in the adrenal gland. We've talked about that before just a little bit, but we're going to talk about it a little more in depth. So the four medications that are in your book for corticosteroids are the most used are the prednisone, methylprednisone, hydrocortisone, and dexamethasone. Those are your most widely used. Okay, there's several in your book. So just take a look at those, and we'll talk a little bit more about the medications. Corticosteroids are also used for anti-inflammatory or as an anti-inflammatory drug. So corticosteroids inhibit COX-1 and COX-2 enzymes that actually start that inflammatory process. So remember, we're treating inflammation because inflammation is typically what is causing pain in our patients, okay? So not only does it inhibit those two enzymes, it inhibits the production of white blood cells, okay? So we all know that white blood cells help our body fight infection. So if you have fewer than normal, you're going to be at higher risk for infection. So we all know there are several types of white blood cells. You have neutrophils, you have lymphocytes, and monocytes. So each of them have a different function. They're either fighting a fungal bacteria or a fungal infection, a bacterial infection, or viral. Okay, so you can see how important it is to maintain that white blood cell count. So if you have a patient who's already immunocompromised, then you're going to have to look at the benefits versus the risks. And I'm sure if they're prescribed, your physician has already done so. So think about it as if they already have a low immune system and we give them steroids, these corticosteroids, then we're going to further deplete that production of white blood cells. So we're putting them at an even greater risk for infection. So in saying that, this would also lead you to think about your patients who have some type of bone cancer, the bone marrow production, because this is where we get our white blood cells, okay? That's where they're produced. So if we're not producing them because we have some type of cancer of the bone and we give them steroids, we're decreasing their immune systems, okay? And they're probably already receiving some type of chemotherapy that has completely knocked out their immune system anyway. Now, again, that's physician specific, and they are actually going to do the risks versus benefits when they're giving them to a patient, who may truly need them. But we need to train ourselves as nurses to kind of think on that pathway. Okay, it doesn't do us any good if we just recognize the fact that corticosteroids inhibit the production of white blood cells. What does that really mean? What do white blood cells influence? Okay, what am I going to assess in my patient? If I only know that it inhibits white blood cells, but I don't know what that really means, then how am I going to know what to assess in my patient? Okay. So when we talk about how do I know whether my patient has a low white blood cell count or not, um, typically the most common cause of a low white blood cell count outside of some type of bone marrow production issue is viral infections. Okay, so typically your physician or doctor, whoever's on call, whatever, is going to order labs. They're going to do a CBC. So with that complete blood count, it's going to give you that definitive information and the amount of white blood cells that your patient has. So just kind of know about that whole process of white blood cell inhibition, okay? So let's talk about cortisol. So I talked earlier in chapter 11 about cortisol. This is almost the exact same information. So natural cortisol is like our body's built-in alarm system. Okay, we talked about how it's our main stress hormone. It's our fuel for our fight or flight instinct. And that this is what helps us keep inflammation down. Remember, it also regulates blood pressure. It can increase our blood sugar because remember, when our stress goes up, so does our blood sugar. Okay, so be mindful of making sure your diabetic patients are checking their blood pressure, their blood sugars, your hypertensive patients. Just make sure that you know what cortisol affects because when you're giving these steroids, you're going to be educating your patient also. We also talked about our wake sleep cycles, and we all know how important sleep is. Okay, if I don't get my 8 hours of sleep, I'm a grumpy person. Okay, I'll just be honest. So without our natural cortisol, we run into various issues. Okay, we have trouble sleeping, we can have weight gain, we run into blood sugar issues, blood pressure issues. Okay, it's just our body's entire alarm system. Okay, so we want to maintain that. Um, Education, assessing, and monitoring. Well, I've talked about a lot of that, but if you read back through page 231 through 234, we're going to go through some more of that, but I just wanted to give you the page number so you can go back and look at some of those things for yourself and just familiarize with those. So corticosteroids as a hormone replacement. I wanted to throw this in so you can see a picture of what Addison's disease might look like and some of the things that they suffer from, because we're going to talk about that when we talk about corticosteroids as a hormone replacement, because that's one of the most popular ones is in fact Addison's disease. So Addison's disease is it's considered primary adrenal insufficiency, and it's basically when your adrenal gland doesn't secrete enough or produce enough of the ACTH, which ACTH is the hormone that stimulates the production of cortisol. Okay, so you'll see in the picture of how greatly it can affect that person when we don't have cortisol. I just talked to you guys about everything cortisol controls and can influence. Okay, so if you have a patient with a diagnosis of Addison's disease, or maybe even before a diagnosis, they're going to have extreme fatigue, weakness, and they're probably going to be very skinny because of the lack of appetite. And you're going to see this picture. She looks kind of dark and bronzy. Usually in the face and hands and the neck, you can see that kind of bronzy look. And it's all because they don't have enough cortisol circulating. Now, they'll also have low blood pressure. You'll see that postural hypotension. Um, and remember, cortisol affects our blood pressure. So um, that's where that hypotension comes into play. And they may have a lot of muscle and joint pain. Okay, so when you look at this picture, you can kind of see why she looks so gloomy, because cortisol affects so many things. Okay, now, of course, again, it affects our wake sleep cycle. So that's where that profound fatigue comes in. Now, when we talk about, or when you look at the bottom, and we talk about adrenal crisis, you may remember this from last year when Miss Party talked about it, but that profound fatigue just comes from the lack of sleep. Okay, that wake sleep cycle, the dehydration, of course. Vascular collapse comes from just that extremely low blood pressure. Okay, and the renal shutdown, again, is from the lack of cortisol. Remember, cortisol affects the kidneys just as well as our circulatory system. So there's an imbalance in that sodium and potassium. So this is truly a life-threatening emergency, this adrenal crisis. So of course we want to treat that. Now, typically, they're going to replace their cortisol with either your patient's going to be taking either prednisolone or prednisone or methylprednisone. Those are typically the ones I have seen prescribed for Addison's disease. But again, it just depends on so many other factors, and it could just be physician preference. So again, be mindful of the fact that corticosteroids are not interchangeable. Yes, I get they sound alike, but remember they sound alike, look alike medications. They're not interchangeable. Okay, so just be mindful of that. You can't borrow from one patient to give to another. Another thing is some of those corticosteroids are also given for different type of visual impairments, any type of visual infections, things like that. So there's various different routes of corticosteroid administration also. Okay, so if you have any questions about Addison's disease, then just please let me know. But I just wanted to let you see that because sometimes having a visual helps just a little bit. So actions and uses. The action of corticosteroids are systemic, meaning it doesn't just go to one site and work its magic and that's it. It means your whole body is affected. Any cell in your body can be affected by the use of corticosteroids, okay? Not just a site of inflammation, okay? So with that being said, your side effects and your adverse effects can be widespread. Now, we use those with caution. And I've talked about why we use them with caution. And we talked about the diabetics, your immunocompromised, those types of things. So with the systemics, typically corticosteroids are given for either some type of an allergic reaction, or I think in chapter 11, I talked about using them for acute injuries like brain injuries, decreasing that inflammation so it decreases the swelling to prevent further brain damage. Okay, severe asthma. You can actually also do local injections of corticosteroids into like the joints, maybe shoulders, hips, wherever, back, either one, just to alleviate some of that pain associated with inflammation in those areas. Um, you can actually, as I said, I think in one of the previous slides, we do have steroids that we use for eyes, ophthalmic use. And then, of course, ear infections. We have corticosteroids for that. And last but not least, you do have some corticosteroids that we use that are inhaled. Those are your lung issues, your asthma patients, or some type of maybe a pneumonia patient, something of that nature. So there's various different forms of corticosteroids, so be aware of using those in various different forms. Okay, so always check that you have the correct medication for the right area that you're or the right route, I guess I should say, that you're intended to give them to. Okay, this is nearly the same exact slide I had in chapter 10. So if you want to go back and listen to the one in chapter 10, just in case I forget to mention something, just review that one also. So corticosteroids mimic the natural cortisol that we're secreting by or in the adrenal glands. Okay, so there's an exaggerated effect when we induce or we introduce those prescriptions of steroids when we have the steroid packs. Remember, I showed you a picture of the dosing packages where we take 6 in one day or something like that, and we taper off. So this is where that negative feedback mechanism comes into play. So we're pumping our body full of steroids, and so the adrenal glands are like, oh, hey, I'm going to take a vacation because I've overworked and I have so much cortisol flowing in the blood, I'm going to have to take a break because they feel like there's sufficient cortisol flowing. So then as we taper, it allows our adrenal glands to pick up on, oh, hey, I'm going to have to get back to work because they're getting less and less of that artificial cortisol in our bodies. So sudden withdrawal is going to throw us into that adrenal crisis that I showed you before with Addison's disease. Okay, so that's why we want to taper them off rather than just boom, stopping those steroids. Okay, so if we did, imagine the havoc it wreaks on our body without that cortisol, blood pressure, blood sugar. You saw all of those things that can happen, and they can be life-threatening, as I said previously. And you can see that also in the slide. So long-term corticosteroid therapy can cause atrophy to that adrenal gland. So just know that. But this is why we use tapering in those doses, is to prevent that negative feedback. Okay. So they must be tapered off, okay, in order to give us the effects that we want and not create another issue with lack of cortisol. So I know I've probably talked a lot about the side effects and some of the adverse effects already, but I want to revisit them just because I want to make sure that we know and understand them because it's extremely important. you're going to see glucocorticoids and those steroids given many times um, over your career, okay, or throughout your career. So some of the common side effects with use of steroids are, even with short periods of time, a week or maybe 2 weeks, is going to be your, of course, your sodium retention, that water retention, increased blood pressure, weight gain, bruising, and then of course your reduced immunity. And again, that goes back to that reduction in the white blood cells. Okay. Um, so again, even difficulty sleeping, we talked about that, some insomnia, because remember that cortisol does affect your wake sleep cycles. Okay, and so some of the other effects that are taking place even with long-term use is going to be thinning of the scalp hair, and you saw that in the Addison's disease. You saw that in the slide with the picture. Fragile skin, they're at increased risk for GI ulcers and bleeding. And then that fat redistribution. I actually had a picture of that one in chapter 10 where you saw the buffalo hump in the moon face. Okay, so that's with normal long-term use. You're going to see that moon face and that buffalo hump. Okay, so that's what we call that fat redistribution. Okay, you might even see it and wonder, what is going on with that person? I just saw them a month ago and they've gained 25 pounds. Well, maybe they're taking some type of steroid, and that's why. So that's some of your side effects and your adverse effects. So again, be mindful of your diabetics. Okay, remember that cortisol affects our blood sugar. So be sure that we're having them check that blood sugar. Okay, and then reporting anything with fever. Okay, because with that decreased immune response, then we may not recognize that illness or something else going on, okay, because there is that lack of inflammatory response. Cataracts, there has been proof of, some studies have proven that long-term use of steroids can in fact cause cataracts. Now you'll also see that I have osteoporosis listed here. Not one we would typically think of. However, corticosteroids do affect calcium absorption. So it decreases our calcium absorption, therefore creating a loss of bone density. Okay, so that's where we get into the osteoporosis. That's why when you go back and you look at the lady in the picture of Addison's disease, she looks like she's slumped over. Okay, so maybe that's a change in her bone structure from that osteoporosis. Okay, hypertension, of course, we've talked about that several times, and then delirium. Okay, so those are just some of the side effects and the adverse effects. So know what those are and know why they occur. Again, corticosteroids affect calcium absorption, therefore we run into risks of osteoporosis. Cataracts occur with long-term use of corticosteroids. Okay, so know those side effects. So drug interactions with steroids. Of course, as your book says, it's going to increase the effects of barbiturates, sedatives, opioids, and then some anticoagulants. Okay, we've talked about a few anticoagulants, but we'll talk about another one. So steroids or glucocorticoids actually decrease the effects of insulin and oral hypoglycemics. And so how that works is with steroids, it actually increases the liver's release of glucose. So we know then it causes or can cause some insulin resistance. So as your diabetic patients or anyone really begins that dose pack, they may see an increase in their blood sugar if you're checking and monitoring that. For diabetics, they're going to see an increased need for insulin. Okay, but as they start to wean off those steroids, they're going to start seeing that decrease in insulin needed. Now, this does not cause a continual elevation of glucose. Okay, it can go up and down. So we need to be sure that we're educating them to check those blood sugars more often than usual, just because of that up and down effect. Okay, it can fluctuate. So just be sure that we're educating them on that. Antibiotics, it also decreases the effects of antibiotics, okay? Now, other NSAIDs and estrogen, of course, increase the effects of corticosteroids. So estrogen, studies have shown that people who have a higher level of circulating estrogen also has a higher level of cortisol. So if we have a higher level of cortisol and we're also taking corticosteroids, then we're seeing a greater effect. So that's how it increases that. Okay, so it's kind of like a double dose of cortisol. Okay. One thing I want to back up and mention to you is with your diabetic patients and the decrease of insulin, you always want to make sure that they have some type of readily available, easily fast-acting carbs, I guess I should say, some type of either glucose gel, fruit juice, something that can raise that glucose quickly if need be. Okay, so always be sure to ask them if they carry something with them or have something available if they were to need that. So going back to drugs that decrease the effects of corticosteroids are your ephedrine, phenytoin, antihistamines, rifampin, and propranolol. Okay. Now, potassium wasting diuretics is one that we need to be mindfully aware of. So if they're taking that diuretic for whatever reason in conjunction with a steroid, maybe prednisone or cortisone or whatever, it increases that potassium excretion. Okay, so if we excrete too much potassium, think about what that's going to affect. If we're hypokalemic and we don't have enough potassium, then what happens? So it's not going to be able to support our nerve and muscle functioning. Okay, so we're going to start seeing some muscle weakness, lots of fatigue, some muscle spasms, and then ultimately some heart palpitations and maybe even some further cardiac issues. So be mindfully aware of those potassium wasting diuretics in conjunction with those steroids. Going back to skin tears with our elderly especially, they're at extreme risk because they have thin, frail skin anyway. Okay, so again, just increasing that bleeding, and that can be a huge issue for them. So if you have any questions about the drug interactions, I try to stress the ones that are extremely important. So if you have any other questions about how those interactions work or why they do what they do with corticosteroids, then just let me know and I'll try to explain that a little bit further. But I hit the highlights of the most important things that you might see again. So DMARDs or disease-modifying anti-rheumatic drugs. Okay, I just simply refer to them as DMARDs. It's easier than saying all of that. So these drugs just reduce the progression of that destruction of tissue that's typically involved in those autoimmune disorders like rheumatoid arthritis. Okay, and if you remember, I talked about tumor necrosis factor and how patients who have those autoimmune disorders have a higher level of that particular TNF circulating. Okay, so DMARDs is typically given to reduce that TNF. Okay, and so by reducing the TNF, we're reducing that inflammatory process. So some of you, if you watch TV, you may have seen commercials about Humira or Enbrel. So how do they work? So there's just a couple of things. They suppress the inflammatory response in order to save that tissue, okay, and allowing your patient to regain some of that joint function with a lot less pain, okay. So they do this by binding to that TNF molecule, okay, that's circulating in there. That would typically enhance that inflammatory response, okay. So by inhibiting that, we no longer have that tissue destruction, or at least we can delay that tissue destruction. Now, I did list the two most common ones there for you, but these drugs are used for more than just rheumatoid arthritis. Okay, some of the other autoimmune disorders like ankylosing spondylitis or psoriasis, Crohn's disease, and then ulcerative colitis. Now, some of you may be wondering what on earth is ankylosing spondylitis. If you've never really been around healthcare or worked in healthcare, then you may not really have ever heard that word. It simply refers to another autoimmune disorder which can involve shoulders, hips, and spine. Okay, there's really there's no cure necessarily for it, but we can slow down the process. Okay, so again, if you were to see ankylosing spondylitis, or if I talk to you about that again, or you see it on a test, as I said, you'll know what that is. It's just inflammation of the joints. It can be in the spine, the pelvic area, shoulders, and hips are also involved. Okay, so those are just a couple of the things that you can also use DMARDs for. So DMARDs, side effects and adverse effects. With these two particular drugs, of course, there's pain at the injection site. Most often they are given by injection. So this can include pain and swelling at the site, some itchiness and redness. And this can last up to about a week. I think your book says a week. So just know to educate your patients about that. Also, take note, this is extremely important when it comes to education. If you are given an injection and your patient is getting this on a continuous basis, what do we want to do? Of course, we want to educate them about rotating the site. Okay, so always make sure you educate about rotating the sites anytime you have any type of continuous injections, insulin or DMARDs, whatever the medication might be. Also, some patients have reported nausea and vomiting as an expected side effect. Okay, now DMARDs actually also reduce bone marrow production, so therefore our patients are at risk for anemia. Okay, so if you're anemic, you know that you also have a greater risk for bleeding. We've suppressed that bone marrow production, so we don't have as many red blood cells circulating, nor do we have as many platelets circulating. So we are at greater risk. Of course, with our bone marrow production, when it's reduced, we are also reducing our white blood cells. So again, that puts our immune system in a compromised status. Okay, so it puts us at a greater susceptibility for infection. Now, adverse reactions are relatively common, okay, in patients who take these. So we have to monitor them very, very carefully. So we've talked about their immune system being compromised. Okay, so you'll see that I've put on this slide that they must be tested for TB prior to initiating any DMARD therapy. Okay, and so the reason for that is viruses, some of those viruses can tend to lay dormant. Okay, so they pose a great risk to our patients if they were to activate or reactivate. So, and this doesn't just apply to TB. Think about shingles. If your patient has a history of chickenpox, okay, we all have that shingles virus probably laying dormant in there somewhere, just waiting for us to overstress ourselves before it rears its ugly head. And if we have a compromised immune system, then we can't fight those infections. Okay, so TB, shingles, hepatitis, all of those. Again, that goes back to making sure that you're looking at those health histories, okay? So another adverse reaction for DMARDs is heart failure. So if your patient may have a new onset of heart failure, or if you have a patient who already has a diagnosis of heart failure, then it can become worse. So again, risk versus benefits, okay, with DMARDs. So know your side effects and your adverse effects and what we're going to do prior to initiating any therapy with DMARDs. Okay, we're reducing that immunity. So think about that compromised immune system and who might be at risk if we were to initiate these medications without really looking at our health history. Okay, if you have any questions about those, again, send me an email and we'll discuss it a little bit further. Okay, so some drug interactions with DMARDs. Of course, some immunizations contain live viruses. Okay, so we do not want to give anyone who has a compromised immune system a live virus. We do not want to run the risk of them developing the disease that we're giving them an immunization for. Okay, just like the flu virus. We have some that are given intranasally, and those are live viruses. Whereas if you take the injection, those are dead viruses. Okay, so just think about why and understand why we would not give someone an immunization containing a live virus. Okay, their immune system is compromised. Now, on the same wavelength, we do not want patients who are taking DMARDs to be taking any other type of drug that has that immune system depression response, okay, or any type of depression of our inflammatory response, like corticosteroids, okay. Chemotherapy, of course, is going to decrease our immune system, but we absolutely want to make sure we look at those drug reconciliations and that they're not taking any other drug that is performing the same action as our DMARDs, okay, that inhibitory response of our immune system. So I said previously that adverse effects are common when taking DMARDs. So I also said that typically they're given by injection. So we need to talk about first dose considerations. Okay, so the first dose should be given by a registered nurse or a physician. Okay, remember, if you're giving it intramuscular or this one is intradermal, I think. Anyway, it's not retractable. Once you give it, it's in there. So if after you give it, there are no reactions, then an LPN may administer the next dose or the next few doses or whatever, simply because of the risk of allergic reactions. Okay, so you have to think about anaphylaxis. So when I think of anaphylaxis, I want to make sure that I have everything available at my fingertips if that were to happen. I don't want to have to run to the end of the hallway to grab a crash cart. So when you are giving a DMARD for the very first time ever, you should keep the crash cart at the bedside for a minimum of 2 hours. Okay, it is imperative because those allergic reactions and those adverse reactions are common. Okay, so it's better to be prepared and have it than to not have it and need it. So remember that. Keep your crash cart at the bedside for at least 2 hours. So as far as monitoring, once you actually give that injection, you're going to monitor that patient every 15 minutes for allergic reactions. Okay, so you're going to be busy with those patients. Now you're going to continue monitoring them again for those 2 hours just to assess for any type of allergic reaction. Okay, so what are you going to assess when we suspect an allergic reaction or even an anaphylactic in certain cases, anaphylaxis? So we want to assess the respiratory rate, of course, and then we want to assess their ease of breathing. You know, are they struggling to breathe? Does it look as if they're struggling to breathe and their airway is compromised? Okay, any type of bronchospasm or bronchial swelling because of that anaphylaxis is going to cause them to struggle with breathing. Okay, of course, check their O2 saturation. Do we have an O2 saturation that's 98 or 100? Or do we have a saturation that's falling below the 60s, the 50s, and 40s? Okay, that's a good indication that they're struggling to breathe. Okay, and then you also want to make sure that you're looking for those rashes and hives at the injection site even. Okay, remember it's going to be painful at that injection site. But we still need to assess for those rashes, hives, itching, anything like that. You always want to make sure you're documenting those reactions, okay, whether they had them or they did not. If they didn't have any reactions, then go into that chart and just chart patient tolerated well, no side effects, no reported side effects, whatever. Just make sure you chart it either way so that someone coming in to give the next dose can look back and say, okay, let's see if they had any reported side effects. Okay, so that's important to chart those. So also when we're talking about planning and implementation and nursing responsibilities, again, this is an injectable medication. So we want to, again, make sure that our patients and ourselves as nurses are rotating those sites. Okay. Now, one thing to be mindful of, and this is in your book on table 12.4, when you're giving those injections and you're giving it near or in the abdomen, you don't want to get anywhere near the umbilicus. Okay, it's full of blood vessels in that area, and I'm sure it's pretty painful. So the absorption of that would be too quick. Okay, so anything that you give near or in the abdomen, don't give near the umbilicus, whether it's insulin or DMARDs. Stay away from that umbilicus. Okay, always make sure that you educate your patient on reading those labels carefully. Storage, do they need to be refrigerated? Can they sit out on the desk? Things like that. Again, do not rub the site after injection. Okay, we don't want to cause any bleeding or bruising at the site. Now, if you have a patient who's taking this because they have some type of psoriasis, remember those are the skin lesions, you want to make sure that if you're injecting, you avoid any area of lesion. Okay, avoid those lesions and avoid that umbilicus area. Now, again, in your book, look again, make sure you understand those nursing implications and those effects. Do not give them to anyone with an active infection, okay? Because our immune response is lessened. Now, again, we want to teach our patients about the signs and symptoms of infection to report. Okay, so you guys know what those are. Make sure you educate your patient about those. Now, remember we've talked about this before, but if your patient is taking this before surgery, then because our immune response is decreased, they have an increased risk for infection. So you have to think about a surgery patient. Let's say they're going in to have open heart surgery or something of that nature. They may be less active. Okay, so you have to think about those patients who might end up with pneumonia. Okay, they're at a greater risk for those things because number one, they're not moving as well or as often, and then their immunity has been decreased. So take a look at all of those. Know about your crash carts, know what you're assessing for when we talk about those allergic reactions or those possible anaphylactic episodes. So know what you're looking for, know what you're assessing for, okay, and know to document. So any other questions that you have about DMARDs, please again, just send me an email and we'll discuss that further. I'm not sure if this is automatically going to take you to this particular link or not when I transfer it into a YouTube video. So if you have just a few minutes to take that or watch this commercial, please do so because it kind of gives you a visual or an audio visual of this commercial and some of the side effects. Normally we get used to hearing the commercials and we don't really think about them, but it may jog your memory when you're test taking. Okay, so just take a few minutes. It's like a 1-minute video and watch about this DMARD. Okay, let's lastly talk about gout and some anti-gout drugs. So gout is a metabolic disorder. It's just when a person makes too much uric acid, which then forms uric acid crystals. So normally our body produces this uric acid when it's breaking down purines. Now, purines is just a chemical compound that's found in certain foods and some drinks. So basically, the uric acid is a byproduct of those purines being broken down. So purines are found in different types of foods. So it could either be a metabolic issue, or you're just eating too many or too much of certain foods that are higher in purines. Okay, so some of those foods that are higher in purines are steak, or some type of organ meat, seafood. So sometimes your gout attacks can be controlled by diet, okay? Eliminating some of those foods that are high in purines, okay? Now, also, I know this is where some of the issues come in when we talk about eliminating seafood, alcohol, and of course, beer and sugary drinks, okay? We're all addicted probably to one or the other. So now let's talk about seafood. When I talk about seafood, there are several shellfish that are seafood items that are listed in your book, and you do need to know these. So that would be your shellfish, sardines, salmon, anchovies, and also pork, and I said beer. So just be sure that you know those foods that are high in purines, because in order to prevent those gout attacks, we need to educate our patients on foods and drinks to avoid. So if we don't know them, we can't educate them. Okay, so gout is really just a complex form of arthritis. Okay, it affects the joint of the big toe most often. It can affect some of the other joints, but it's typically the big toe, and it causes severe pain. If you've ever suffered from gout, then you can relate. So the uric acid crystals that are formed, they basically deposit into that joint, and that's what's causing that severe pain. It's typically very sudden, and there's pain and redness and even swelling at that joint. Typically, again, the big toe. Now, anti-gout drugs are given to prevent gout attacks, or in hopes of preventing them, to reduce that uric acid also. So sometimes if it's not an issue with diet, people just aren't metabolizing, or they can't metabolize those purines correctly, and so they have an extra store of that uric acid. So if it's actually, obesity can also, I think your book talks about obesity can also increase your risk for gout. Now, I did tell you that gout attacks are typically sudden, and so the medications that you're taking for the gout itself is not going to help with the pain and inflammation. Okay, so they're probably going to take some type of NSAID for that, okay, some ibuprofen or whatever, to relieve that inflammation and swelling, and therefore reducing their pain. Okay, so if you look on page 237, you'll see the two drugs that are in this category, and that is your alpurinol, which is the one I see most prescribed, and then your febuxostat, that's what I call it. I don't know how you're going to say it, but anyway, those are the two. The one I see most is, again, the alpurinol. So just take a look at those on table 12.5. Okay, so let's talk about the uses, side effects, and the adverse effects. The primary use of anti-gout drugs is to prevent gout attacks. So given that information, we have to talk to our patients about compliance. They have to take it every single day, or it's not going to work. Okay, if they're taking it and they do have a gout attack, let's say they eat something, that's full of purines and they have an attack, then it hopefully will shorten the length of that. Now, when we talk about some of the common side effects, if I could talk, I'm sorry, that's going to be your headache, your rash, and your nausea. Now, with nausea, we know to always suggest that they either take it with, a snack or maybe a meal. Okay, so some of the rare side effects, rare means they've been reported, but apparently it's not a common thing. So that's going to be your erectile dysfunction and your gynecomastia in men. Okay, so sometimes if they know the rare side effects or that there's a possibility of that, they may be less compliant in taking them, okay, or resistant to taking them to start with. So some of the other interactions are going to be with your antacids. Of course, antacids, inhibit the absorption of many things. So we want to make sure that they take them 3 hours, at least 3 hours after taking some type of antacid, okay? any type of aluminum based, anything, Tums, whatever. Make sure that they know to take it 3 hours outside of that 3 hour window. So alpurinol actually interferes with warfarin. Okay, so your patients who are taking alpurinol for gout and taking warfarin for whatever reason are going to need, they're going to need to monitor those INRs, those levels that we do blood draws for, so that we can make sure that they're not at an increased risk of bleeding. Okay, we want the INR to be within normal range. Okay, so with that being said, if they're taking an anti-gout drug and warfarin, then their dose may need to be decreased based on those INR results. Okay, so they need to go and have their INRs drawn frequently and make sure they're within the normal limits, so the normal ranges. Because if they're not, then that warfarin dose may need to be reduced. And you need to know that, because I can promise you, you're going to see that again. So just know how it affects warfarin and what we need to do as far as nursing interventions and education. We also want to make sure that as far as education, we educate them on drinking plenty of water. Okay, that will help to get rid of some of that uric acid. Okay, will help to excrete that. So when we're talking about education, with antacids and warfarin, also continue to educate them on that. So make sure that they're keeping all appointments for the laboratory testing, anything as far as the bleeding or again, effectiveness. Okay, we want to make sure that it's working. Okay. Okay, so again on teaching, we want to educate them on the adherence to dosing requirements. This is a daily medication, okay, in order to prevent those gout attacks. We want them to take them with meals. Again, if they are less likely to eat a full meal, then make sure they take it with a light snack. That's just to avoid that GI upset, okay? Hydration status, we want to encourage them to drink plenty of liquids, typically about 8 to 16 glasses, I think is what your book says, of liquids. We want to encourage them to drink water, because that water is going to dilute those or that uric acid. Now, we did talk about taking those aluminum-based acid antacids, and we wanted to make sure that they're at least 3 hours in between taking those with their anti-gout medications. We want to assess pregnancy status and whether they're breastfeeding or not, because these drugs do cross over into breast milk, and the effects on infants have not been proven. So we don't know. So always assess for that. Diet restrictions, of course, again, educating them on the foods that are high in purines and also the drinks, the beers, the sweet tea, sugary drinks, organ meats, all of those seafood items we've talked about. And then, of course, the big one is always keeping the follow-up appointments for labs. Again, this medication does interfere with the metabolism of warfarin, so they need to have the INR so that we can see whether or not those doses of warfarin need to be adjusted. And typically it's going to be a decrease in warfarin. Okay, so make sure that you understand that when we talk about or when we're testing. Okay, so keep all those appointments, know what it does to warfarin, know what you as a nurse are going to suggest they do, and then what to expect from your physician if those INRs are in fact out of the normal range.